First of all, I'd like to thank the organizers and the foundation for putting this program together. This is my first time in Krakow, and I've been truly blown away by your hospitality and your beautiful city. I wanted to thank you. And amyloidosis is probably arguably the most difficult disease we are hearing about today. It's because of the host factors, how the patients present at the time of diagnosis, and the fact that most of the therapies that we're utilizing, we're extrapolating from other plasma cell neoplasms. So, what I try to do, I do want to mention that before I came to the Levine Cancer Institute about 3.5 years ago, I mentioned that I'm a biology disciple. I was the director of developmental therapeutics at the University of Arkansas, and Dr. Barlogi was my mentor. And everything that I've achieved in my career so far is because of his mentorship. All right. Having said that, I will talk about systemic AL amyloidosis, kind of go into some details about diagnosis, pathogenesis, and therapy. And I'll try to give a little bit of a historic perspective. I have to say that my talk is 80% the same talk that I gave 10 years ago when I was a fellow in training, with only few data that have been added in the last couple of years that are adding an extra dynamic to this particular presentation. This appears to be an exciting time, relatively exciting time for systemic AL amyloidosis patients. Then I'll touch upon POEM syndrome, how to diagnose the pathogenesis, and what we know about therapies. So amyloidosis, the term amyloidosis comes from the deposition of amyloid protein in different organs. The disease is fairly rare. These proteins, the amyloid proteins that get deposited, they change the conformation, aggregate and form fibrils within different organ systems and cause organ damage that way. The term itself is fairly non-specific. It was first described by Rudolf Virchow in the 19th century based on some of the biochemical properties of this protein and how it interacted. The amyloid protein is of many different types, at least 25 different subtypes that we know of. The way that we approach identifying amyloidosis is by thinking of it in three broad categories or umbrellas. We have primary amyloidosis, also called the systemic AL amyloidosis, which will be the focus of my talk. Then secondary amyloidosis, or AA amyloidosis, occurs due to serum amyloid A protein deposition and is commonly seen in association with chronic inflammatory conditions. It almost always never produces clinically relevant heart disease. Then we have senile or hereditary amyloidosis, which occurs due to gene mutations in transthyretin protein that gets deposited. For the most part, that kind of disease occurs in the 7th or 8th decade of life rather than earlier. It has a much slower time course than amyloidosis. The focus of my talk today primarily will be the immunoglobulin light chain amyloidosis, or AL. And AL occurs because of a dangerous small B cell clone that can make a lot of misfolded protein. That protein can be heavy chain along with a light chain, but half of the time it's a light chain. And of that's 53%, 3/4 is lambda light chain. That misfolded light chain protein can be proteotoxic to the different organs. It also intercalates with cell and microenvironment, with metals, proteosomes, and causes oligomers, which also cause proteotoxicity. And those amyloid fibrils deposit in different organs, causing organ dysfunction and reduced survival. And 3/4 of the patients are already presenting with fairly significant heart involvement. Over half have NYHA class 2 or above. 68% have kidney involvement. Of those, 42% are presenting with nephrotic range proteinuria, 45% with florid renal failure. then liver, GI, soft tissue, and peripheral or autonomic neuropathy symptoms are also seen in a group of patients. But one of the things I want to highlight is that AL amyloidosis is not myeloma. It's a very different disease. Myeloma is a high-burden disease. It's tumor-mediated organ dysfunction. Amyloidosis has low tumor burden, and it's a protein-mediated organ dysfunction. So even though we're approaching or utilizing therapies that are extrapolated from the myeloma realm, we really need to think about amyloidosis a little differently. Then you do have a small group of patients who have both amyloidosis and myeloma. They present with high burden, and they have both protein and tumor-mediated organ dysfunction. This is a rare disease. Roughly 3,300 cases of AL amyloidosis are diagnosed in the United States, and another roughly 800 of non-AL cases are diagnosed. And where does AL amyloidosis originate from? Usually from MGUS. So this is Dr. Bob Kyle's classic paper that was published in NEJM. A lot of times we're quoting this 25% relative risk rate of MGUS going to develop smoldering or active myeloma, but forget about the 7% risk of amyloidosis in these patients. So when you're following MGUS patients, it's important not simply to be on the lookout for myeloma progression, but also look out for amyloidosis. And that's probably one of the most key points on this particular slide. Jorge has already discussed IgM lymphoma and macroglobulinemia. Clinical presentation-wise, the patients usually present with several characteristic kind of features. Periorbital purpura or raccoon eyes used to be one of the classic presentations taught in medical school. Macroglossia, nail dystrophy. So macroglossia and nail dystrophy can be seen. And then patients present with apical systolic function that's preserved, but they have diastolic heart failure and a monoclonal protein. And they have thickening of their intraventricular septum and may have low voltage on their EKG. When you have those findings, you have to suspect that the patient may have amyloidosis. There are certain things that you have to do to look for organ dysfunction, and then you also need tissue diagnosis. From the tissue diagnosis perspective, depending on the organ of involvement, a tissue biopsy, which could be renal, a lot of aggressive cardiologists, while they're doing catheterization, would actually do a cardiac biopsy as well. And then abdominal fat aspiration for Congo red staining can also be done, although the yield there is questionable. Then you're looking at other tests for organ function like serum creatinine, eGFR, 24-hour urine proteinuria, along with serum electrophoresis and immunofixation. In amyloidosis, unlike myeloma, most of the proteinuria is going to be albumin. You may have a small urine M component, but usually it's albuminuria. Then liver function test. Clotting abnormalities can also happen in amyloidosis patients. Factor Xa deficiency is well recognized as something that patients may present with. Then EKG, and then these cardiac markers are important, and I'll come to this a little later in my presentation. So NT-proBNP and troponin T and I are going to be important prognosticating cardiac involvement. And these are the usual biopsy findings. So if we do get a tissue biopsy, this is the Congo red staining in kidneys showing this deposition of amyloid protein. Getting an electronic microscopy, you'll see this green birefringence. And if you're doing a fat pad, Congo red staining with polarized light can show up like this, as shown by these specific arrows. Typing of the amyloidosis is imperative. So we have to figure out what kind of amyloid protein the patient has, AL amyloidosis or TTR. Mass spectrometry is usually done by a referral center. So in the United States, a lot of mass spec is done by Mayo Clinic for confirmation. So once you get mass spectrometry, if it's AL, then the patient gets a bone marrow and you proceed with subsequent other evaluations. If TTR gene sequencing is done and there's a mutation, and it's an autosomal dominant familial amyloid cardiomyopathy diagnosis, genetic counseling is recommended because that is just one family member. You have to start thinking about other family members that may be affected. Usually the therapy for that kind of disease is organ transplantation. You cannot do a lot of therapeutics at this point. For wild type, age-related cardiac amyloidosis is usually the diagnosis in that case. So lab testing, serum protein electrophoresis, monoclonal lambda or kappa light chain spikes may be seen. Free light chain assays are utilized, and lambda, again, more commonly is seen. The presence of urine or serum protein electrophoresis is only suggestive. So tissue diagnosis is extremely important for these patients. We see a lot of African American patients where the TTR gene mutation is heterogeneous in about 5 to 6% of the patients. So a patient may present with an MGUS and may actually have a TTR-like amyloidosis at the same time. So that's where the mass spectrometry becomes extremely important in those patients. Ekg findings, this is low technology kind of a thing that you can actually do and help suggest a diagnosis. Low voltage is seen in limbs. Limb bleeds occurs in about half of the patients. But there are other abnormalities like first-degree AV block, tachyarrhythmias, non-specific intraventricular conduction delays, ventricular tachycardias, and second or third-degree AV blocks may also occur in patients. Echocardiogram findings are fairly characteristic. So you have a thickened intraventricular septum that's very generous in this echocardiogram. The amyloid infiltration of the heart increases the echogenicity. And so there's a granular pattern. The critique with echocardiogram is you have to be a good reader to actually catch this. And there is reader-to-reader variability in echocardiogram. Cardiac MRI, on the other hand, is more sensitive to the findings of amyloid protein deposition because you can see the gadolinium enhancement of the myocardium, which is global throughout, as well as subendothelial. So most amyloidosis programs are utilizing it during the diagnostic workup, especially for patients who may have normal echocardiogram findings, but the cardiac biomarkers and the patient's symptoms are suggesting things otherwise. So, going back to the future, AL amyloidosis in the 1990s, there were no effective therapies. Median survival was 12 to 18 months. Survival with cardiac involvement was only 3 to 5 months. Cyclic MP was the standard of care. Rare hematologic CRs, negative SPEP or 24-hour UPEPs, organ responses were rare. By the time these patients were showing up, they were so sick that it was very difficult to give them any therapy. If you already have NYHA class 3 symptoms and you already have 3 plus peripheral edema and other organs affected, it will be very difficult for you to treat that kind of patient. So the algorithm in the 90s, I'm going to go not through this part, but kind of focus more on the light chain AL part, is stem cell transplantation with high-dose melphalan and Meldex were the two therapies that were being utilized more frequently based off of series or single-center data. And depending on the patient's performance status and organ involvement, if they went to CR or stable disease, they were just observed. If they didn't go into a CR or progressed or were relapsing, patients were pushed towards a clinical trial. That is how we used to think about these patients. But into the 2000s and then beyond 2010, there were clinical studies reported on the use of high-dose melphalan on its own, either having a bortezomib dexamethasone induction followed by bortezomib and melphalan combined transplant, or high-dose melphalan followed by bortezomib dexamethasone consolidation. So looking at Meldex, Cyborg-D, high-dose melphalan on its own, patients may be achieving hematologic CR, which is just disappearance of the urine M or the serum M protein, but we're not having good organ responses without high-dose melphalan. So that was an observation that was seen in some of these series. Now, The only randomized trial that we have, and this is a very small study of double-digit patients on both arms between melphalan, dexamethasone, and high-dose melphalan, favored survival for melphalan and dexamethasone. But the study was critiqued because of the N or the size, as well as the stratification in the two arms. But it still remains the only randomized trial we have comparing these strategies. Dr. Wiesel actually presented or published the CIBMTR analysis on high-dose melphalan and autologous stem cell transplant. And the reason why I want to look at that original analysis and then a follow-up analysis almost 9 years later is because I want to focus on this early treatment-related mortality with high-dose melphalan. So as you can see, the original paper, when it was published, the one-year survival was 66%, and the survival was lower in cardiac patients at 56%, and the 30-day treatment-related mortality was 11%, much higher than what we would expect with myeloma. So this is a difficult patient population to treat. But over time, as transplant centers became more attuned to treating these difficult patients, the survival started to improve. So when 9 years later this study was published, the one-year survival had improved to 75%. Even cardiac survival had improved over that time period, and the 30-day treatment-related mortality had been cut down to 5%. And if you start breaking that down into different eras, you can see that the treatment-related mortality of this group of patients from 2007 to 2012 is much lower than the earlier groups of patients being, from the earlier time points. And if you break down the number of transplants being done at different centers, there is certainly a difference between the centers who are doing more versus the centers who are doing less. So TRM, with autologous stem cell transplant, is not simply dependent on the disease features and host factors, but the expertise of the center. And this group, this early TRM group is extremely important. So that group really hasn't changed a lot if you look at, the initial 12 months over here. Sorry, this is days. So initial 2 months, the early TRM, it really hasn't changed over the last 20 years of doing autologous stem cell transplant. Outcomes overall in AL amyloidosis have improved. This is the UK National Amyloidosis Center database, looking at roughly 17 years of data and 23 years of data by the Sweden group. And overall survival, even though it has improved by using anti-plasma selective directed chemotherapies, the early mortality remains unchanged. And in 94% of the cases, it appears to be cardiac mortality. So Shaji Kumar looked at a large series of patients with systemic AL amyloidosis, trying to tease out the cardiac involvement, looking at certain cardiac biomarkers. So this is troponin T, proBNP, and also looking at the free light chain difference, involved versus uninvolved. And the threshold for abnormality are right here. And based on having no abnormality on these thresholds, the patients were divided into stage 1. If you had one of them, stage 2. If you had two of them, stage 3. If you had all three, stage 4. And you can see that, if you divide patients by cardiac involvement staging, it does drive outcome in patients, regardless of whether you look at from the time of diagnosis or time from transplantation. And the interesting thing is, if you look at this early treatment mortality group, apart from the stage 1 group, where the survival appears to be good even in that early time period, if you have stage 2 or above disease, you are at a higher risk of dying, regardless of what kind of intervention you're going to be getting. So the current treatment approach for most systemic AL amyloidosis patients is looking at performance status, organ involvement, and then looking at these cardiac biomarkers. And if based on performance status and organ involvement, you may be deemed low risk, high-dose melphalan is still considered a first-line therapy for patients. If the performance status is good, but the cardiac biomarker is questionable, it's reasonable to give combination chemotherapy to patients. And many times, when we give induction therapy to these patients for 2 or 3 months and reduce the plasma cell burden, their performance status actually improves, and they may then be eligible for an autologous stem cell transplant. But if patients have high cardiac involvement degree, then you have to be cautious with chemotherapy. And even the doses and regimens we utilize have to be attenuated for patients. I do want to bring up this cardiac transplantation because some of the US centers are doing this for their patients. In general, the earlier series of cardiac transplantations for systemic AL amyloidosis involvement were high morbidity procedures. And despite cardiac involvement, the survival was not improved because we did not have effective anti-plasma cell therapies. But that may actually change in the newer series because of the availability of better tolerated plasma cell-directed therapy. So what's recommended if a patient is young enough to undergo a heart transplantation, then it might be feasible to actually give them high-dose chemotherapy and autologous stem cell transplant within a 12-month period. So the Boston University has been a proponent of that kind of approach for a select group of patients. But what would be the optimal strategy in getting to this disease is not simply by killing the clonal plasma cell disorder, but also trying to do something about the organ dysfunction and deposition. So there are several monoclonal antibodies in clinical trial. I will highlight the NEOD-001 molecule a little bit more. There's some data with organ response by using a very cheap drug called doxycycline in the post-autologous stem cell transplant setting presented at last year's ASH by the British group. And then within the clonal plasma cell disorder therapy domain, we have certain antibodies, dara and elotuzumab. Daratumumab probably is going to be the first one that gets studied. But venetoclax is another drug that you've heard about that drug for different indications throughout the day today. So NEOD1 is an antibody that neutralizes and disaggregates circulating soluble amyloid. And it also clears deposited and soluble amyloid by inducing macrophage just to phagocytose the amyloid. So it's essentially removing the protein from the tissue, which is pretty exciting. So Dr. Maury Gertz presented this data at ASCO last year, and it's now published in JCO. So this was the phase 1/2 trial design. Small group of patients, but considering that this is AL amyloidosis, this is a pretty decent number of patients. There were 7 different cohorts of patients, and they started at a very low dose and just kept on escalating the dose. And then there was an expansion cohort of patients with cardiac, renal, and peripheral neuropathy involvement. So their primary endpoint was, it's a phase 1/2, so safety and tolerability. The patient characteristics, there were a third of patients with 1, 2, and 3 and more organ status. And median time since last plasma cell-directed therapy was 5.4 months. And this is quite remarkable. So looking at all the response evaluable patients as well as all patients in general, and looking at their cardiac marker, pro-BNP, pro-BNP declined in patients regardless of the dosing and the duration of therapy in those patients. And the response was defined by the Palladini definition. More than 30% decline and more than 300 picograms ml decline in anti-pro-BNP. The same response was seen for renal biomarkers as well. So proteinuria change, again, this is the Palladini definition. Looking at, evaluable patients as well as all patients combined where the data were available. So this was quite remarkable. It wasn't simply, patients having a hematologic response, but organ response was also seen. So a large global study, randomized phase 3, is being done. It's a double-blinded placebo-controlled trial where efficacy and safety of this NEOD-001 is being evaluated, comparing, you're taking standard of care, NEOD versus placebo, and it's a double-blinded trial. So it's ongoing. It's been ongoing for about a year and a half, accruing slowly because, the trial criteria is fairly restrictive. Based on the patient population we don't want patients who have limited cardiac disease, and we don't want patients who have a lot. But most of these patients are presenting to us with advanced cardiac involvement. So accrual has been a little slower than expected. So the main takeaway from amyloidosis side of the talk is, recognizing the clinical symptoms and signs of these patients is important. As hematologists, if we're seeing MGUS patients and we might be following them in clinic, look out for amyloidosis, not simply for myeloma. And a thorough workup for the type of amyloidosis is important. Treatment decisions are based on performance status and the degree of organ involvement. And, we're targeting amyloid with immunotherapies, which is representing a new way in developing therapies for AL amyloidosis. So remember, it's not simply about trying to kill that plasma cell clone. We have to figure out how do we reverse the organ dysfunction in those patients. And the second topic I'm going to talk about probably, over the next 6 to 7 slides is poems. And honestly, we haven't done a lot in poems. So I'm honestly going to be talking about, the disease, its characteristics, and some of the anecdotal things we have from the treatment perspective. But poems originally was diagnosed as osteosclerotic myeloma with neuritis and other striking features in a case report. And then by the 70s and 80s, there were several different case series that were being published. There were reports from Europe as well as from Japan. Initially, the syndrome was known as Scro-Fuchs syndrome or Takatsuki. Sorry. I think we need to brighten that light because I need to wake up a little bit more. Takatsuki syndrome. But POEM stands for peripheral neuropathy, organomegaly, endocrinopathy, monoclonal protein, and skin changes. The criteria for diagnosing POEMs was developed by the Mayo Clinic colleagues. They had published this series back in the early 2000s. Angela Dispensieri was the first author. And almost all patients had polyneuropathy, monoclonal plasma cell disorder, and sclerotic bone lesions. Then there were certain other features that were associated with this disease as well. So the diagnostic criteria looks at one of these major criteria, having at least one of the major criteria and one of the minor criteria. But almost all patients inadvertently have polyneuropathy along with monoclonal plasma cell dyscrasia. And almost always it appears to be lambda. In terms of pathogenesis, nearly all cases, as mentioned, have light chain disease, and it can be confused with Castleman's disease due to the angiofollicular lymph node pattern of hyperplasia. Then bone sclerosis, and the cytokine profile also appears to be a little different. If looking at the cytogenetics by FISH abnormalities, usually translocation 414 is not something that's seen in POEMs. There is a smattering of similar plasma cell disorder FISH features compared to MGUS, AL, and multiple myeloma. Looking at the cytokine profile, and this was, again, some of the work was done by the Mayo Clinic group, secretion of interleukin-1 beta, TNF-alpha, IL-6, IL-2, and interferon gamma appears to be significantly elevated compared with multiple myeloma patients. So some of the cytokines that are not increased are IL-4, IL-10, and TGF-beta-1. So this appears to be an acute phase reactant kind of a pattern that we're seeing. The other thing that was observed is super elevated VEGF levels compared to normal and MGUS patients. So VEGF is something that we do measure when we are trying to diagnose patients with POEMS disease, especially if we are trying to tease this out from Castleman's disease, where IL-6 may be elevated, but VEGF is usually not. Looking at the treatment strategies, these are usually symptom-driven. So looking at sclerotic bone lesions, if it's only the bone that's involved, that's causing the discomfort, radiation therapy can be utilized to palliate those patients. Alkylator-based therapy may increase the response by about 40%. Corticosteroids, about 15%. But high-dose melphalan with autologous stem cell transplant as a one-time therapy results in more than 90% improvement in patients' disease symptoms. Looking at the kind of responses patients overall get and looking at the survival of all the 99 patients in the Mayo Clinic experience, if you look at the time and months, POEMS is not a super aggressive disease. Regardless of whether you treat with conventional alkylators or high-dose therapy, they appear to do well overall compared to some of the other plasma cell disorders. Looking at the autologous stem cell transplant experience, however, looking at a group of 27 patients, there appears to be a flattening of that curve with high-dose melphalan. Experience with novel agents is very anecdotal. There are case reports in series of Len-based combinations, Len-Dex and Len-Cytoxan-Dex, Bortezomib-Dex, Cybor-D, and even RBD. Bevacizumab alone or in combination with chemotherapy has been employed in the past, but with mixed results. So these are, probably, this is not something that we usually recommend for patients who may not qualify for autologous stem cell transplant, but, either bortezomib or Len-based therapies may be feasible. Again, making the right diagnosis is key because there are features in POEMS that are, overlapping with Castleman's disease. And that is a distinction because, there are different therapeutic approaches taken for both those diseases. High-dose melphalan and autologous stem cell transplant still remains the favored strategy for this group of patients. Novel agents may be utilized for salvage therapy. I believe this was my last slide. I truly appreciate you taking the time and listening to me. Thank you very much.